Good evening, and thank you everyone for joining us tonight. Sorry we're running a couple minutes late. My name is Garry Olney, and I'm the Chief Executive Officer for the two South Bay Providence Medical Centers, Little Company of Mary San Pedro and Little Company of Mary Torrance. As our community continues to reopen, several community members have asked me, how is COVID impacting our local community? Our goal this evening is to provide the community with an update on where we are in the life cycle of the virus, and most importantly, what we need to do individually and as a community to stay safe. We will also discuss the preparations and actions Little Company of Mary is taking to address a resurgence of the virus. We know a lot of people are confused by the different reports from the news media, especially when it comes to how many COVID positive patients are in our community and what we need to be doing to prevent becoming infected or transmitting the virus. It is important to mention that when it comes to reporting the number of COVID cases, the South Bay is rolled into what we call the Los Angeles County. Dr. Sircar, an infectious disease practitioner who previously worked with the CDC during the Ebola outbreak, has been a godsend to our medical centers, providing leadership and education to our entire medical staff and all of our employees regarding the COVID virus. She will share with us the facts regarding the virus, as well as what we need to know about protecting ourselves and our families. Thank you for the great questions that everyone on the call today submitted for discussion. Several questions that were sent in were about specific situations such as, should I travel to see a family member, or is it safe to send my child to school? Our intent this evening is to provide you with facts that will help guide you in understanding the realities and the complexities of this pandemic so that you can make your own informed decisions. We will, however, answer many of the questions that you submitted about testing, the safety of our medical centers for care, screenings, elective procedures, the COVID vaccine, any type of vaccines, and other treatments for COVID-19. For the rest of the presentation, you will be able to see the slides of the presentation and you'll hear my voice in the background, but this will allow, by me not being on camera, the presentation slides to run more smoothly. This slide shows the number of COVID patients that have been treated at Little Company of Mary since the pandemic started. As you can see, our Providence Little Company of Mary Torrance Medical Center had a high of 83 COVID positive patients in the second week of April. That number began to drop off significantly to a low of 19 patients in late May. However, we are now seeing the number rise since the beginning of June, and as of today, we have 43 inpatients with a diagnosis of COVID. We have experienced an 8% increase in cases over just this past week. Early in March, I made a strategic decision to keep our medical center in San Pedro clean. What I mean by that is we don't admit patients that are COVID positive to that medical center. We transfer those patients to our medical center here in Torrance. This strategy has allowed us to consolidate the expertise, staff, supplies, personal protective equipment, and testing to one location as we call a center of excellence for the treatment of patients with COVID, enabling us to provide the highest level of quality care to patients being treated with the virus. One of the most frequently asked and important questions our team is asked is, do we have enough personal protective equipment, what we call PPE, and COVID testing? The benefit of belonging to a large health system is that we have the ability to purchase personal protective equipment and COVID testing supplies in large volumes and to deploy these supplies to medical centers in greatest need. Since the pandemic began, Providence has been able to source and supply the necessary PPE and COVID testing supplies, along with many generous donations from our community and corporate partners. This slide is a snapshot of the weekly COVID update communication that we send to all our employees, medical staff, and board members to ensure they are kept informed. One of the standard items on the update is the supply of personal protective equipment, PPE. Providence has at least a 2-week supply of personal protective equipment on hand at all times. With the very real possibility of a second wave of COVID and the flu season just around the corner, it's important that we continue to stockpile supplies and sustain our policies regarding proper use of PPE, disposable of PPE, and using PPE for reprocessing when appropriate. The update that's on the screen also provides employees and physicians the number of patients we have tested for the COVID virus and the number that have tested positive. As you can see, to date, we have tested 9,830 patients and employees in our skilled nursing departments, which is required by the state. In the past month, we have seen the positive results increase to 17%. We will provide a link at the end of this presentation and in a follow-up email where you can access this information yourself. I would also like everyone to know that Craig Leach, the CEO at Torrance Memorial, and myself have been in constant communication. Our goal is to share information with each other and to ensure that our hospitals are addressing and meeting the needs of all of our employees, physicians, and most importantly, our community. Our next topic is about the efforts we are taking to keep our hospitals, employees, physicians, and the community safe. First, we had to implement a very strict visitation policy. The policy is aligned with state and federal regulations and other large medical systems. We know the policy is working by the fact that we have not had any patient-to-patient transmission of the COVID virus. This slide provides an overview of the policy, and it also will talk about the exceptions that we make to the visitation policy. So we allow 1 visitor for those that are having same-day surgery or procedures. We allow visitors for patients that are at end of life. We allow visitors if there is a minor that has been admitted to the hospital. We allow visitors, and I mean visitors, the husband and wife or the parents of any child that's in our neonatal intensive care unit. We also allow visitors for patients that are in the maternity ward having a baby. We allow visitors for patients with mental illness or dementia. And then we have what we call a compassionate exception. If there is a family that really feels that they need to be with their loved one, we have a process that the family can access for a compassionate exception. We know that the presence of a loved one is incredibly important for patient healing, and our hospitals are making every effort using technology to allow families to stay connected. And as I noted, we do have a process to ensure compassionate exceptions that can be made. Our spiritual care employees have a key role in making these important connections. The next action we took early in March when the virus was first identified was to implement a COVID screening process for anyone entering the medical centers, which includes all employees, all physicians, and all vendors. Everyone entering the hospital is screened for fever and symptoms of the virus. Anyone with a fever is not allowed to enter the medical center, and anyone who is working that develops symptoms are sent home. And we also provide a mask for anyone that is allowed to enter the facility. Additional efforts to keep our hospitals safe include we isolate any patient that is COVID positive to specific areas of the hospital. We call it cohorting, so that there's no danger of transmitting the virus to another patient. Our operating rooms are not in close proximity to the dedicated COVID units. All operating rooms and COVID rooms are cleaned with the Xenix robot that uses an ultraviolet light to kill germs. As I said earlier, our San Pedro Medical Center does not admit COVID positive patients, so we keep that facility clean. We also have increased frequency of cleaning waiting areas, exam rooms, elevators, elevator buttons, and restrooms to ensure a very high level of disinfecting. We implemented measures that ensure we meet all social distancing directives in all areas of the medical center. We provide private rooms for patients who are not COVID positive. And all patients having essential surgeries or procedures receive a COVID-19 test prior to their scheduled procedure to ensure their safety and to prevent anyone from entering the medical center who may be COVID positive. One of the questions sent in for tonight's presentation was, is it safe to have an elective procedure at the hospital if it will require rehabilitation at our skilled nursing facility? Well, we know there are many stories about nursing homes having an outbreak of the COVID-19 virus, both infecting patients and staff. But I can assure you that we have developed strict policies and procedures to protect our patients and staff that work in our skilled nursing facility. While I cannot comment on other facilities, I can say with confidence that the policies and procedures developed for both the medical centers and the skilled nursing center are effective in protecting our patients and our staff. With what appears to be the resurgence in the virus, it's important for the community to know how we are prepared for a second wave of patients being infected and hospitalized. In March, the state highly recommended that every medical center develop a plan to deal with a surge of COVID-19 patients. Both of our medical centers developed plans that expand our current capacity by an additional 40%. The plan provides for increased bed capacity, which includes increased ICU beds, ventilators. We have today 148 available ventilators on site, and personal protective equipment to support the second wave of COVID. And as I reported earlier, we have 2 weeks of personal protective equipment on hand at all times. Before I turn tonight's presentation over to Dr. Sircar, I want to acknowledge the community's outpouring of support during the COVID-19 pandemic. The support has been amazing. Our medical centers have received monetary donations, gifts of personal protective equipment, meals to help nourish our frontline employees, and cards and notes of gratitude to all of our caregivers. This support from the community has inspired each and every one of us. Many community members continue to ask, what can I do to help? As you may know, the pandemic has had a tremendous financial impact on all hospitals in California. As a not-for-profit Catholic organization, we exist to provide community benefit and to offer high quality, compassionate care for all, including the poor and vulnerable. If you want to know how to best support us at this time, please consider making a monetary gift to our Emergency Response and Relief Fund, so we have available resources to help address whatever needs arise in the future as we continue to care for the South Bay community. Now it is my pleasure to introduce Dr. Anita Sircar. Dr. Sircar grew up in Rolling Hills and attended Chadwick School in Palos Verdes. Her father was an orthopedic surgeon. Her mother was a nurse, and her older sister is in epidemiology for the CDC, also working on the emergency COVID response in Atlanta. Dr. Sircar is deeply rooted in this community and in service to others through the medical profession. She went to UCLA for her undergraduate degree and completed her infectious disease fellowship training at UCLA Cedars-Sinai Medical Center. She holds a master's in public health and a diploma in tropical medicine and hygiene, and has worked extensively in international settings with organizations such as the CDC, the World Health Organization, UNAR, and Doctors Without Borders. She spent 3 years at CDC headquarters in Atlanta before moving back home to California, and was deployed to several countries on several public health assignments and emergency responses, including Guinea, West Africa for the Ebola response in 2015. She brings her expertise in infectious diseases as a staff physician at Providence Little Company of Mary Medical Centers and as a clinical instructor of infectious diseases at UCLA. We are grateful for her willingness to share with us this evening. Dr. Sircar, take it away.
Good evening, everyone. Thank you, Gary, very much for that introduction. And thank you for inviting me here this evening to speak on COVID-19 and give a community update. I hope I'll be able to provide you with some useful information as well as answer some of the really interesting questions that were emailed to us earlier this week. It is important to remember that this is still very much a pandemic in evolution. So I'm going to preface my entire talk by saying that everything that I say today could change tomorrow. That's how quickly things are evolving. If you remember the invitation for this talk, one of the topics was to talk about reopening. And as we've seen over the last few days, we're actually talking about closing things again. So just to kind of keep that in mind, that this is not set in stone, and it hasn't been for the last 3 months. So before we talk about what's happening at the community level, let's take a minute to talk about how we got here in the first place. So if we roll it back all the way to the end of last year, on December 31st was the first reports of this new cluster of pneumonia cases coming out of Wuhan, China. 2 weeks later, it was reported outside of China for the first time in Thailand. A week later, the first case was reported here in the United States in Washington State. 6 days later, we here in California had our very first case. That was 6 days later. 6 weeks later, on March 11th, the WHO declared COVID-19 a global pandemic. And 8 days later, California, which is the largest, most populous state in the United States, was the first state to go under lockdown with the stay-at-home orders put in place. Although this seems like a lifetime that we've been doing this, it's only been 112 days since COVID-19 was declared a pandemic, and it's only been 104 days since California went into lockdown. So where are we now? Before I talk about what's happening here at the community level, let's talk about this from a global perspective. So I'm going to zoom the lens all the way back and see where we are from a global standpoint, and then bring it here to our neighborhood. So as of yesterday, there are over 10 million cases worldwide and climbing, and over 500,000 deaths and climbing. If we look at this map, and this is from the Johns Hopkins dashboard, the country with the highest number of cases in the world is the US, shortly followed by Brazil. The country with the highest number of deaths is also the US, with Brazil following shortly behind. So that's where we are from a world standpoint. So how are we doing in the United States? As of yesterday, we have 2.6 million cases and over 120,000 deaths and rising. If we take the United States and we divide it by county and we look at the number of cases and deaths by a county level, we will see that Los Angeles County is the county with the highest number of confirmed cases in the United States. Los Angeles County is also within the top 5 of the highest number of deaths in the United States. So this is a pandemic. This is an outbreak that is very close to home for us. You may talk to family members or friends or loved ones in different parts of the country or the world, or even in different parts of California, and they will have a different understanding and experience than we are having here. So this is something that is very close to home and is very real for us. If we look at what has been happening so far, we've had about 40,000 new cases, however, a day in the United States. But as Anthony Fauci warned us yesterday, that if we keep accelerating at the speed that we are with the number of new cases, we could start to see 100,000 new COVID cases a day in the US. If we put that in comparison to a country like Canada, who has only had 106,000 cases for the duration of the entire outbreak, that is an alarming number of new cases for a single country to have. So how are we doing in California? As of yesterday, California has over 200,000 cases and about 6,000 deaths. One thing that has changed and evolved over the last 3 months is the demographic of who we're seeing cases and deaths in. And recently, in the beginning of this outbreak, it was a lot of elderly people that were coming into the hospitals from congregate living facilities. Lately, we've been seeing that the majority of cases are between the ages of 18 and 49. 57% of the cases that we're seeing now are within this age group. However, the number of deaths that we're seeing are still 78% in the category of 65 years and older. We've also been seeing statewide that the number of cases and deaths is disproportionately affecting the Latino community. 56% of all new cases are in the Latino community, as well as a significant amount of deaths. We're also seeing that cases and deaths seem to be affecting males more than females. And if you ask me what my demographic of COVID patients in the hospital is this week, it is exactly this. It is Latino males between the ages of 18 and 49 that we are seeing more hospitalized now than we were early on in this outbreak. This has been reported in the news lately that 56% of people now diagnosed in California are in our younger population, whereas less than 15% are in the age group of 65 and older. So why is this important? This is important because when you have a cohorting or mixture of a younger group of relatively healthy, possibly asymptomatic people, cohorting in small spaces with an older population, whether that's going to a party or living in the same house with them, the risk of transmission from asymptomatic younger patients or younger people to the older population increases the risk of severity of infection or severity of disease progression. So now that we're seeing this shift in the younger population, the messaging has to be to this group to be very mindful of who they spend time with, especially if it's the older people that they live with at home or that they share common spaces with. So from March 10th till today, we went from 1,000 cases to 230,000 cases and rising. This is an alarming rate of increase. So sort of stem this tide, the governor has put new orders in place statewide and countywide to try to slow this down. So on the 18th of June, an order was put in place for the mandatory masking because at that time, the highest recorded number of cases in one day in California was 4,233 cases, where only a few days later, we topped over 8,000 in a single day to be the new record high for a single number of cases in a single day. The other thing that we should look about is what's happening here in Los Angeles County. For us here, which I showed you is the #1 county with the highest number of cases countrywide, we are also seeing an increase in number of cases. As of yesterday, there's over 100,000 cases countywide and over 3,300 deaths. The graph on the left looks at the number of cases cumulatively over time from the beginning of March until yesterday. And some of that could be because we have increased our capacity for testing, is why we're seeing an increased number of cases, but that shouldn't reflect what we're seeing in hospitals. We're starting to see an increase in the number of hospitalized patients with COVID-19, almost to the level of where we were at the peak of this outbreak for us, which was around mid-April, and that is slowly climbing. To try to stem the tide of the spread here in Los Angeles County on the 28th, which was just a few days ago, the governor closed down the bars. On June 12th, bars were opened as part of a stage 3 planning to reopen the city. At that time, there was over 130,000 cases in California. By the time he did close down the bars on the 28th, there were over 216,000 cases. So if you look between June 12th and June 28th being about 16 days, and this virus has an incubation period of 14 days, it's almost predicted that by opening the bars early, we did see an increased number of cases over 2 weeks later. The other thing that he's tried to do to roll back some of this acceleration is to close the beaches for the holiday weekend. And just a few hours ago, he actually closed the restaurants. So this is what we're looking from an LA County level. So let's look at where we are in our own neighborhood. So here is a map of the South Bay, and each of these lines demarcates a city in the South Bay. The greater the intensity of blue is the greater number of cases. So if you look for where you live on this map, you can see that there are no cities that have not been affected by coronavirus. And this is a gross underestimate of the number of cases that are actually circulating in these cities. Part of this is because we still don't have enough tests to do universal testing. So the numbers that we are seeing are mostly in patients that have been symptomatic enough to go and get a test. So the true numbers of how many cases are still very much underrepresented by this graph. So who's at risk? Who's at risk of having severe illness from this infection? It still remains the same. We're still seeing that people who are over the age of 65 are at greater risk for complications and severity of diseases, as well as people who live in congregate living facilities, whether that be a nursing home or a long-term care facility, or even the prisons. And then people with underlying medical conditions such as chronic lung disease, heart conditions, immunosuppression, or dialysis or liver disease. The symptoms have also been something that we have been learning have changed, or that we've been detecting in patients over time. So as this virus is evolving and as we're understanding it more, we're starting to understand how symptoms present as well. The majority of symptoms are still fever, cough, shortness of breath, chills, muscle pain, the sort of influenza-like URI, upper respiratory infection type symptoms. But as of 2 weeks ago, the CDC added 3 more symptoms to what our understanding of this virus is, including congestion or runny nose, nausea or vomiting, and diarrhea. And probably the most important symptom of all is our understanding that there can be no symptoms at all and still be, people can still be infected or be carriers of COVID-19. What is our understanding of transmission? Our understanding of transmission has also evolved over the last 3 months. A few weeks ago, the CDC put out a publication that said, based on their best understanding and their study of the transmission of this virus, it is still mainly transmitted from person to person within close contacts, and that's within 6 feet, in a respiratory droplet, meaning that the longer somebody interacts within a closed space within 6 feet of somebody else, the higher their risk of COVID-19. There's also been greater understanding of asymptomatic and pre-symptomatic spread of this infection. Asymptomatic meaning people who have coronavirus or carrying it, but will never develop any symptoms. They have it's unknown to them that they're even carrying this virus. And pre-symptomatic meaning people who don't even have symptoms, but can shed virus, but will later go on to develop symptoms. In their best understanding, 35% of all people with COVID-19 show no symptoms, and 40% of all transmission occurs prior to symptom onset, which makes this virus a very clever one because it can be passed between person and person without either person even knowing that they have it. There's also been some studies about surfaces, a lot of discussion about how long a virus can live on a surface. It is possible to be infected if you touch a surface that has virus on it and then touch your eyes, your nose, or your mouth, but this is not thought to be the main way of transmission. The main route of transmission still remains person to person within close contacts through respiratory droplets. Spreading from animals to people is very low, and it's very rarely spread from people to animals. Testing. Testing is a lot of questions are asked about testing. Where we are today is probably not a lot better than we were 3 months ago in terms of having enough tests to test who we would like to test. So there was a question on what are the types of tests. There are basically 2 kinds of tests available right now, a molecular test and an antibody test. A molecular test is one that is used to diagnose infection for right now. It is usually a nasal or a throat swab, and you can have no symptoms after exposure, and it will most likely be positive 3 to 5 days after an exposure. It's most likely to be positive 3 days after symptom onset. So if you were exposed to somebody with COVID-19 today and you went and got a test later on this evening, most likely you would have a negative test because you need some time after exposure for that test to even have a fair result. This test tells you if you're infected right now. If the test is negative, it doesn't mean that you have immunity. And there has been a lot of problems with there being false negative tests, either because people are being tested too early or in the way that the sample is collected. An antibody test, on the other hand, is a blood test that tells you if you were infected in the past. It can't be used to make a diagnosis. It can't tell you if you're infected right now. And it has the best chance of having a result 10 to 14 days after an infection. The problem with the antibody test is that it still can't tell us right now if these antibodies that are detected provide protection, nor can they tell us how long this protection will last. So we ask about who should get tested. This was another question. Because the answer would be everyone. If we had enough tests, that would be the right answer. But given that we still don't have enough tests to test everybody that we would like to, there is a prioritization of who should be tested. Priority is given to hospitalized patients that have symptoms of COVID-19, people who work in healthcare facilities, our first responders, and people who are living in congregate living facilities like nursing homes or group settings. The next level of priority goes to patients who have symptoms but are not necessarily meeting criteria for the priority above, or if the local health department or public health is asking for a test for public health monitoring. That's the other priority. And of course, the last category would be people who don't have symptoms. And if we did have enough tests, these would be the group that we'd be testing widely. Another question that was asked was, is it worthwhile to get an antibody test? And the answer to that is, well, yes, if you are curious about having a prior infection. And I highlighted the word curious because really the utility of this test is just for curiosity's sake. So if you were to go out and get an antibody test, you have to keep in mind that it's still unknown if the antibodies that are detected provide immunity from reinfection. It still can't tell us how much antibody is being made or how protective it is or how long those antibodies will last for. And there's been a high number of false positives in this test. Some of it has to do with the cross-reactivity with other coronaviruses. So if you go and get an antibody test, just take the results with a grain of salt. Having antibodies does not mean that you have immunity, not currently with the way the tests are today. So all of the health messaging of wearing a mask and social distancing still apply, even if you do have an antibody test that is positive. Lots of questions too about where to go and get tested. There is an LA County website that can tell you areas around where you live to go and get tested. Some of them require appointments, but this website is a really good source to find out places near you where you can go for testing. Lots of questions about treatment, so we'll run through this pretty quickly. One of the questions that was asked this week is, why is hospitalization so long when a patient has COVID-19? This is a yes/no question. In the beginning, yes, hospitalization of our COVID-19 patients were taking longer, and that's partially because us as physicians and nurses and healthcare givers were learning about this virus as this virus was spreading. So our understanding, our treatment plans, our developing of what to treat which patients with took some time to understand and get used to. There's also no one single treatment for COVID-19. It still is a treatment that is basically supportive care. All of these medications that I have listed here on the left are medicines that have been repurposed for use from other diseases and other infections. And the primary goal of all of these treatments that you're seeing here are to mitigate the effects of this overwhelming inflammatory response in the lungs called ARDS, or acute respiratory distress syndrome. And this is the biggest challenge with COVID-19 is to stop the progression of this inflammation in the lungs that makes it very difficult for people to breathe. So as we've been learning more about what works and what doesn't, and as there's been more treatment available to us for our patients, we have gotten better. And so there are quicker turnarounds of our patients that are hospitalized, but the severe cases still remain in the hospital longer than the less severe ones. Treatment, again, like I said, there is no FDA-approved single treatment for COVID-19. The FDA uses a pathway called Emergency Use Authorization, or EUA, to fast-track some of the medications that are coming through clinical trials. Recently, they gave an FDA EUA for remdesivir, which is an antiviral that we have available here and that we've been using. But again, most of our treatment is relegated to supportive care. Dexamethasone, which was in one study, has shown some survival benefit. It is a commonly used steroid that's mostly available in all hospitals in the country. Convalescent plasma, which is taking antibodies from somebody who's already cleared their infection and giving it to somebody else, is also being used. And hydroxychloroquine, which in the beginning was being sought after and used more widely, has not shown the benefits that we once thought that it would. Another question that came through was, do you anticipate there might be something like Tamiflu that can be taken to mitigate the effects of COVID-19? So there is a broad spectrum oral antiviral that is being looked at. It's so new, it doesn't even have a name. It's called EIDD 2801, which is in phase 2 trials. And this would be, and the hope is, an oral regimen, something like Tamiflu, that could accelerate the time to recovery for patients who are infected, and it could be something that could be taken as an outpatient. Because as of now, remdesivir, which is an oral which is a broad spectrum antiviral, it can only be used in the hospital because it's intravenous only. Lots of questions about vaccines. When is there one? When will we have one? The U.S. has 3 vaccine candidates that they are funding under a pathway called Operation Warp Speed. Moderna, which is the first one to go into a phase 3 trial, will start this month. Moderna is hoping that they will have a vaccine available and ready for distribution by the end of this year or the beginning of 2021. So 3 vaccines being looked at. One to start in July, one in August, and one in September, to look at safety and efficacy of these for COVID-19. Question that was asked this week is, can the flu shot and pneumonia shot protect me from COVID-19? The answer to that is no, not directly. The virus for COVID-19, which is SARS-CoV-2, it needs its own vaccine. However, vaccination against other respiratory illnesses like pneumonia or influenza is highly recommended, because having coronavirus plus another respiratory infection could be even more dangerous and deadly. So when we get to flu season and it's time to take your flu shot, or if you're ready to get your pneumonia vaccine, it's highly recommended that you get those 2 shots. So the big question that I think all of us are asking is, what steps can we take to live our lives as safely and productively as possible while offering support to those most vulnerable? And this was a very good question, because I think this is the challenge that we're all seeing in this outbreak, is how do we live our lives and move forward, but still protect those that would be most critically ill if they were to get infected. And there really isn't much more to say than what has already been said, that all of the messaging for protecting yourself and your loved ones really comes down to behavior. Washing your hands, maintaining the physical distancing, wearing a mask, wiping down high-touch surfaces, whether that's in your car or your phone or doorknobs. You avoid touching your face as much as possible with your hands, staying at home from work if you're sick. Avoid interacting with the more vulnerable population. So if you are in a mixed household of older people with younger people, try to maintain as much social distancing, especially when we know that the most at-risk population is over the age of 65, where the highest population of positives now are the younger 18 to 49-year-olds. That could be a very dangerous combination if the interaction is for too long. Try to avoid large gatherings or parties, and participate in contact tracing. And this is something you may have heard about recently. So what is contact tracing? Contact tracing is basically a simple sort of confidential process that public health uses to slow the spread of infections and avoid outbreaks from spreading. So if you are exposed to COVID-19, you may get a phone call or a text message or an email from public health telling you that you've been exposed. They won't tell you who exposed you. It'll be confidential, the person that you were exposed to, and they will offer you free confidential testing. They will keep in touch with you, see if you develop symptoms, ask you about questions about where you've been or people you've spent time with so they can inform those people as well. And none of this information will be shared. And then if you test positive, they will give you advice on how to keep yourself safe and your family safe, as well as give you information about treatment. And all of your information will then be confidential from that point on. So if you do get a call and you want to protect yourself and your community and those around you, contact tracing is something that you want to participate in. The bottom line, especially going into the 3-day weekend for 4th of July, think about what kinds of activities that you're doing and where it sort of falls in the risk stratification. Lower risk activities are usually the ones that are less crowded. So going for a walk or a bike ride or getting takeout from a restaurant is considered a low risk activity, whereas medium risk may be taking an airplane or having a backyard barbecue. And high risk activities still remain concerts, bars, gyms, and sports stadiums. So try to maintain social distancing and choose activities that are lower risk. So to end this, recently the WHO Director General said that this is not even close to being over. It's agreed that we all want this to be over. We all want to get on with our lives, but the hard reality is this is not even close to being over. And this is true. We are seeing that not just here in LA County, not just in the South Bay, but worldwide. There's a lot of work still to be done to keep this infection, this virus from spreading. So important things that you can kind of do is settle into this idea that this may be the new norm for a while. It's really important to keep up with guidelines and stay informed, not from a global perspective as much as what's happening in your own neighborhoods. 2 really good websites to go and get good information about that are the CDC and LA County Department of Public Health. That puts real-time information up there that can be useful to you and your community. Another important thing that you want to do is don't delay your own medical care for things that are non-COVID related. You shouldn't be scared to come to the hospital or to see your doctor if you're having chest pain or you have other medical problems that you think deserve attention. Don't delay your medical care. It'll be worse in the long run. Feel safe going to the ER and your doctor's office. Wear a mask, wash your hands, physically distance yourself, and be patient and be flexible. As you can see in the last few days, things are ever evolving, things are changing, things will change again, but things will get better. And I think the most important message here is to have hope. And I really liked this that I found here that says, hang on, pandemics end. And that is true. All pandemics end. That is why I'm not talking about a Spanish flu patient that I just admitted, because that pandemic end. So we want it to end and we want to be around to see it end. So just be patient that better days are coming, and they will. I want to thank you for your time, and I would like to introduce Dr. Vornes. One of the most asked questions that we have had is it safe to go to the emergency department? And the answer is yes. We know some individuals have delayed their important care due to fears of catching COVID-19 at the hospital. So we've asked Dr. Vornes, chair of the Department of Emergency Medicine and a board-certified emergency physician, to answer that question.
Thank you, Dr. Sircar. That was such an amazing overview and lots of great information. And yes, I'm here to talk briefly just about the experiences that we've had in the emergency department. Early in the pandemic, early April, everyone was told to stay home. Everyone stayed home. ER visits dropped quite a bit, and it was a necessary thing for us to adapt and change to the new pandemic. We've learned to deal with it. We've learned to keep people safe in the emergency department at the same time as dealing with patients who had COVID that were very sick, who needed to be intubated, and so on. So once we kind of got that all figured out, we still noted that a lot of people decided not to come to the emergency room and delayed their care. And we've done a lot of measures to keep you safe. One is we built a tent outside the ED for cases that were low risk that wanted to be tested. We kept them out of the hospital in general. We have a dedicated unit within the emergency room where any COVID suspected patient is brought directly there and not commingled with any other of the emergency patients. If we have an ambulance run that comes in, they're held outside until we have a safe COVID room for them to be roomed in. They're not in the hallway. They're not waiting inside the ER to get to a room. They're held outside. So this is some of the things that we've done in the ER to keep people safe and all our patients safe. What we did notice in the middle to late April, the volumes of the ED was extremely low. And then when we did start to see patients come in, they were tending to come in too late. They were coming in too late for their heart attack. Their heart attack or stroke was too late to treat, and we didn't have all the options we wanted to treat them, and they had worse outcomes. People were waiting too long to come in for their abdominal pain, and their appendicitis were being burst. So those are things we don't want to happen. And to this date, we have not had one transmission from a patient to another patient within our ED or hospital. And that just speaks to all the different measures that we've been taking to keep you safe and the community safe. We've also kept our waiting room with social distancing. We've kept the waiting room rapidly clean so that the chairs that the patients sit in are clean constantly. And again, we've done all this for the safety of you and our community, and also in the same time we've taken great care of all of our COVID patients. So that's about all I have, and I will turn it back over to Garry.
Thank you, Dr. Vornis, and thank you, Dr. Sircar, for your time this evening and all the great information that you provided. And I want to thank everyone this evening for attending our update. We hope you found the update interesting and informative. And on this slide, it gives you some additional information on where you can go for COVID information. We also want to let you know we plan to have another community update like this sometime in August. And look for an email from us early next week where you'll be provided the link to this presentation. Also want to let you know that this presentation will be on our hospital's Facebook page. And then when you do receive the email early next week, please respond to that email with any questions that you have or any suggestions on information you'd like us to bring to the community update that we plan to have in August. And with that, I just want to thank everyone and hope everyone has a good evening. Thank you.